Welcome to Direct Primary Care Benefits Podcast, your resource to understanding how DPC and the direct care model is fixing healthcare for employers and individuals alike. Learn from the most innovative and disruptive business executives, brokers, physicians, and healthcare influencers that are in the trenches, changing the way employee benefits are being administered across the country. I'm your host, Brett Shoemaker. All right. Well, welcome everybody to episode 1 of Direct Primary Care Benefits Podcast. This is your host, Brett Shoemaker. And today we are very fortunate and blessed to have a good friend of mine that I've known for, I think, David, close to a decade now?
I think around
Pretty close, right? So I've got Mr. David Balat here, and David has a pretty robust background in healthcare. He is the, I don't want to mess up the title, but he is on the Texas Policy Foundation. So David, why don't you introduce yourself to all of our listeners out there and tell them a little bit about who you are, what you do, your background, and then we'll dive into transparency in healthcare here.
Sure. I've been in healthcare a long time. My running joke is that I'm a child of immigrants, so I was supposed to be a doctor, but it didn't turn out that way. But that didn't mean I didn't start out in hospitals. I worked in hospitals ever since I was old enough to work. Been through just about every department, and then switched gears in college and went the administrative route, which is where my skill set ended up being. And ended up being a hospital executive. Worked in group practices, hospitals. Many different organizations related to the healthcare industry. Had my own companies where I became a consultant for hospitals that were doing poorly financially and did turnarounds, many of those in rural community, physician-owned hospitals, you name it, had some connection to it in some way. And then just really became disenchanted with healthcare overall. Was very frustrated with what we weren't able to do for patients, especially with regard to the pricing. And so I had the opportunity to run for public office. I ran for House representative in Congress and lost gloriously in Houston. But really, I was thankful for that because I learned a lot, and it opened up a pathway and a doorway for me to get onto the policy side, which is a lot of what I do now. When I lost in the primary, I really didn't want to go back into what it is that I was doing. So I really self-funded my own campaign in healthcare reform, and I would just talk to whoever would listen. Well, didn't know who what would come of that, but I got picked up by the Texas Public Policy Foundation, and I also started my own healthcare coalition called Free to Care.
I love it. Well, I just learned something right now, David, talking to you. I had no idea that you actually started Free to Care, so that is awesome. And, I'm glad you were campaigning for yourself because, as a matter of fact, when we met at a business meeting one afternoon, you were actually there and talking about I believe you even mentioned direct primary care the very first time that we ever spoke and talking about the alternative ways to do healthcare. And so it's amazing how God works. And we're sitting here on this podcast today talking about changing healthcare and how direct primary care is a huge component to making that happen. Absolutely.
It's one of the things I'm pretty passionate about. I use direct primary care for myself and my family. But I just believe in it because it takes us back to the way healthcare should be conducted, and that's between doctor and patient, medical professional, and people receiving care. Right now, one of the reasons why healthcare is so expensive, so inefficient, and just doesn't work right is because there are too many middlemen that have injected themselves between the primary stakeholders, which is doctor and patient.
Yeah, absolutely. And David, when you talk about that, let's really dive into that because I know the biggest thing that we talk about, and I know there's a lot of policies right now that talk about transparency. So can you maybe shed a little bit of light on what these new policies are and what some of these things that are coming down the pipe in terms of, hospitals being transparent with their pricing, telling patients and or prospective patients what the pricing is. I know I just heard a story from Dr. Goyle that was talking about a surgery that his wife had, and it was a major. I won't name the name of the hospital facility, but basically, they had priced, I think it was like $75,000 or $80,000 for a surgery. And that wasn't for the doctor. That wasn't for anesthesia or any other applications. It was literally just for the hospital room. But then when he said he was cash pay, all of a sudden it was a 50% lower price. So can you speak to that?
And that's still too high.
Yeah.
No, absolutely. I can speak to that. The gross charges in a hospital, those are works of fiction. And I can get into why prices are artificially high. It's not just the hospital's fault, although a big piece of the blame is on them. It's also the way that insurance contracts are structured, because many of those insurance contracts have language in them that say, we're going to pay you whatever we negotiate, or your charge, whichever is less. So it's incumbent upon, you really have a legal responsibility as a fiduciary of a hospital then make sure that you're not leaving any money on the table, right? So you have to make sure that all your prices are across all of your thousands of contracts are higher than the highest negotiated rate. And so those gross charges really are meaningless numbers. And for them to put them out there as the price is not appropriate, accurate, or just in a lot of ways. So let's talk about what the prices are. The prices are, if you have Aetna, if you have Blue Cross, if you have Cigna, the negotiated rate between the hospital and your insurance company, whether it be an employer or one of the big companies I just named, that's the price, that negotiated rate. So they should be able to give that to you, and it's important for you to know that, because as with deductibles as high as they are, we're essentially cash buyers. We're cash shoppers. So it's important to know if somebody's negotiated rate for a CAT scan is $2,000 and hospital B over there, they've only negotiated $1,200. It's worth it to me to know that I can save $800 by driving maybe 5 extra miles.
100%. Yeah, no doubt. Let me ask you this, because when we talk about pricing and being, transparent with the pricing, many doctors are, leaving the traditional, fee for service practice and moving to the direct primary care model. And obviously, there's a lot of advantages. Obviously, the value and the overall continuum of care is on a whole nother level. But can you explain to me, because obviously the business model is advantageous, not only, for time and on the patient side, but obviously there's a financial reward there as well. Wouldn't it be advantageous for hospitals to be more transparent and eventually get, paid up front, even though it's less, but not have to worry about all the administrative costs? Because I'm sure you can speak to the administrative costs that are existing in, traditional practices as well as hospitals, right?
Yeah, well, they've already invested in that machine. They have that administrative cost. It's fixed. They've got it. And so the idea that they're going to make everything transparent, which some are now, but it's just the biggest culprits, the biggest bad actors are the bigger hospitals, the bigger systems. Some of them, even faith-based ones, have said, well, we're not going to do that. We're not going to be transparent because we don't want to divulge to our competitors what we're able to do. Well, that's not doing much for your community as far as I'm concerned. And it's not in line with your mission as a faith-based organization. And my common response is, shame on you. Because there are a lot of people that, well, let me step back and say this. As Americans, as people, we're pretty good at shopping for things. And when armed with the information, we can make good decisions that are in our best interest. Employers certainly want that. People certainly want that. And overall, it's only going to make the entire market better. The hospitals and the hospital systems that are first to market with making things bundled and transparent, I think are going to have a competitive advantage.
100%.
And if not the first to market, the second to market for sure.
Yeah, 100%. I mean, Amazon has got us trained well, right, to look at the reviews and see the reviews and the pricing. I mean, when I look at First Primary Care, when I look at our reviews, I mean, if somebody went and looked on there, I mean, if you didn't know anything about direct primary care, you could literally just go to the reviews, David, and learn all you needed to learn about what type of care is being provided. And I think that that's 100% key and critical to what you're saying is these hospitals that, turn the corner and make those decisions to be transparent and share what those bundled pricing costs are, then that's just going to further educate and incentivize more competition in the marketplace, which is what you're all about, right?
Yeah. With direct primary care, if I could say just a little bit about that. When I tell people about it, the response often is, what's the catch?
What's the catch?
That's too good to be true. It doesn't work that way. And do they take my insurance? Those are a lot of common things that I hear. And you know what? It's not too good to be true. It really should be the way things work.
Isn't it amazing how we have the entire world trained to think that if they have an insurance card, they have insurance, when really what they don't even realize that they're holding is really just a card to give somebody else a bunch of money and give them more money out of their pocket. And instead of that, if they just educated themselves and listened to a podcast like this or got a direct primary care physician, they would learn the tricks of the trade, if you will, and be so grateful that they had somebody that was advocating for their care and showing them the better way to consume healthcare.
Well, don't get me wrong. It's a pretty card. It's a nice looking card.
Some of them are even glossy, right?
It's so glossy. But, it really doesn't do us a lot of good when you're talking about primary care. Because, look, when you're talking about direct primary care or even cash, you're paying significantly less than if you're using your insurance. If you're going to buy medications, even if you have a $30 copay for your medication, most generics are under $10. So you're immediately paying 3 times what you'd normally pay by using your insurance. Not to mention, that's not even the limit on what your employer with the insurance company is paying for that medication. That's just the copay. So insurance, it's counterintuitive. They're supposed to be the big buying group that's supposed to keep things more affordable and lower cost. It's the exact opposite. So for a lot of employers that hopefully that are listening to this podcast, and you should if you're not, you need to think about having a direct primary care, not just because of the incredible care that you get at the affordable rate, but also how they're able to navigate you through the healthcare system, because overall, they'll keep you out of the ER. They'll keep a lot of people out of the hospital. They address the needs of chronic patients, and they can help you shop for medications that are affordable. So they do a much better job than what insurance companies should be doing.
Yeah, because they're actually out there fighting for their patients, right? And that's the beautiful thing that I think a lot of people, when they look at the whole subscription model as a whole, the subscription model was designed, just by the nature of its design to, encourage people to stay healthy, right? If we had patients, if every patient was constantly calling the doctor and we weren't doing a good job at, doing the overall health coaching, how you sleeping, how you eating, what is your stress levels like? If we didn't do a good job doing that, then we would be flooded with, inbound requests or inbound, care needs. And when your direct primary care doctor is doing all that health coaching and really taking your overall care into account rather, I mean, you're in the best hands you've ever been in. And I got to tell you, when we talk about the pricing and how inexpensive things can really be done in healthcare, I always go back to, when I first started telling the story, when I first started with direct primary care, and you were really the person I remember, reaching out and calling you saying, "Hey, have you ever heard of first primary care? Do you know about this concept?" And you were like, "Yeah, this is what I've been talking about." Right. So, but when I heard the story of one of our patients that didn't have insurance, that had a kid that I think fell off the swing or the monkey bars or something, and then the next day, was swollen and had some pain still, and we were able to get him over to an imaging center to get an x-ray done. I think it was maybe $30-$40, less than $50, and then connect him with an orthopedic to get it set and casted for less than $500, all in the same day on a Monday at that. I mean, it really wasn't believable even for me, right? Because it's like, why have we been paying thousands of dollars for these services when there's doctors that are not only willing to do it, but they're nowadays, they're more interested in finding direct care relationships than they are going the insurance route. I mean, to me, it's just crazy. David, maybe you can speak to this. Why do you think it has taken, 70 years for us to come up with these models and these solutions? Do you think technology has played a major role? What do you overall think is driving this massive growth in the direct primary care space, and, you know, driving brokers to start to get more creative and really teaching employers how to consume healthcare the right way. What do you think is driving that?
Well, I don't think it's a new model at all. I think it's one of the oldest ones. You know, when you look at the typical Norman Rockwell picture of the doctor with the black bag going to your home and spending time with you, and in exchange, you know, getting a few dollars, whatever their fee was. We're coming back to that. That's where we are today. Now,
beautiful.
We've got a few more tools in our tool belt, like being able to reach your doctor remotely via FaceTime or text or email, or whatever the case may be. Those are added tools in that little black bag of that doctor now. But it's not anything really new. It's something really quite old that we're coming back to because maybe that's the way medicine is supposed to be delivered.
Yeah, absolutely. Well, I couldn't agree more. Let's shift gears here for a second. And you do a lot of press releases and articles and talk about PBMs and all the middlemen in between. And I don't want to get you too flustered here because I know you're super passionate, as you mentioned earlier, about this, but talk a little bit about PBMs, what they are, and what is causing these astronomical costs for prescription drugs, and some of the things that have been done to kind of circumvent this.
Sure. You know, a PBM is a pharmacy benefit manager. This is an organization often used by your insurance company because they will go out on behalf of the insurance company to go and get drugs that they can put on the formulary. So an insurance company, what they have is a drug list. It's a list that they have of approved medications for the benefit year. And they can pull some on and off, but you know, every year some may come on, others may come off, and they bounce back and forth. Well, the reason why PBMs are largely engaged today, even though the price of medications continue to go up, you would think, well, they're not really good at their job because the price of medicine keeps going up. Well, if you really look under the hood, they're the reason that medication prices are going up, because they were given an exemption under a law called the anti-kickback statute at the federal level in 2003.
The anti-kickback statute that gives kickbacks.
Yeah, so they were basically given a get out of jail free card from the anti-kickback statute. So the federal government said, you know, you are now allowed, as a part of your business model, to conduct kickbacks. You can get, and they call them rebates in the PBM world. So they now have the same business model as the mafia.
Goodness gracious.
So manufacturers have to accommodate these larger and larger rebate requests. And the only way that they can vie for being on that formulary is by giving a bigger rebate. Well, the only way you can give a bigger and bigger rebate is by increasing the list price. Does that make sense?
Amazing. Yep, it makes complete. It doesn't make sense, but it makes sense what you're explaining.
So since 2003, you can actually track. It's an exponential curve, the increase in medication prices. Now, there have been some years of stabilization and some years of there being a dip, but overall, there's been an increasing price curve, and the PBMs take this rebate, they keep a little bit of it, and they give the majority of it back to the insurance company. You know, in Texas, we mandated what those rebates were and how much was kept by patients and how much was kept by the insurance companies. And as of, I think it was 2020, there was $5 billion in rebates.
Wow.
0.03 was kept by or given back to the patients or the employers. Nearly 100% was kept by the insurers and the PBMs. Now, when they were called out on that by some of the lawmakers, they said, "Well, we're using that money to help keep premiums down
by driving them up." Interesting.
Well, the response is there's been premium growth every single year. Where's this downward pressure from? Say the $5 billion. Did that really all go to the premiums? Were premiums supposed to go up $5 billion more in that year, and they still went up in double digits? That seems highly unlikely.
So So what's the solution?
The solution, well, there's several solutions. One is transparency, as we've said. I think the more we know, the more pressure we can impact these organizations. I think there, like I said, there are various ways to get to a solution. The easiest and best way is for employers to hold their third party administrators accountable and say, we want to know where this money is going. Where are the rebates? How much money are you making, Mr. Broker, on incentives and bonuses based on the PBM's revenue model? Asking these questions and holding, you are a fiduciary as an employer under ERISA law, but many employers they don't have the expertise, and the irony of all that is that they don't really seek out the expertise in their business to help them with this number 2 or 3 line item budget in their business. You're a healthcare company essentially because you're spending so much money on benefits.
Absolutely.
So with as much money as you're spending, invest in the expertise to get you a better deal, whether it's through a consultant that will work with your broker, a broker that you pay a fee to as opposed to a commission, having a direct primary care doctor that is your chief medical officer that is helping you navigate the population of your employee base through the healthcare system. There's lots of solutions, or you could incorporate all of them. But that is the single best solution to changing the system, is getting the employers to change their behavior.
Getting the employers to understand that they actually have choices and can create their own healthcare plan. It's amazing. I was just sitting down having lunch with a gentleman who owns a couple of urgent care centers, and we were just talking about business overall and exactly some of the same things we're talking about right now. But one of the things that I find amazing is the amount of people that aren't familiar with all these discount programs that are out there. And I think it gets to a point to where there's so many. But can you speak to, GoodRx and some of these discount coupons that are out there, and really just educate the listeners on what the differences are, because I remember when I was first a little over a year ago looking into understanding what PBMs were and these discount coupons were. I mean, it was like a whole new world out there, right? So can you speak to kind of where they're similar, where they're different, and, just how consumers can participate and be better educated?
Yeah, absolutely. Scriptco, in a way, is a PBM, but what they do is they offer coupon codes, and they have an ad, or not an ad, an app.
Did you say Scriptco, David?
No, not Scriptco. I meant GoodRx. GoodRx is that they have an application. You go on your phone. I encourage everybody to download it. And if you have a drug that you know of, you can find the best price. You can shop the various pharmacies so that you can get that done. Now, there are other pharmacies that are online pharmacies. Mark Cuban has Cost Plus Drugs that he just recently released. His is just a portion of generic drugs, but they have very transparent pricing. There's another company called Scriptco. Scriptco is a direct pharmacy. They don't make any money on the sale of their drugs. They actually, and they have all generics, by the way. So whatever they pay for a generic, that's how much you pay. Well, how do they make money? Well, they charge you around between $9 and $10 a month. And that's the only way that they make money. Anything else that you buy, you're paying their cost. They're not the only ones. There are other companies that are starting to surge into the market because everybody is seeing the need.
Yeah, 100%. And then not only that, you see pharmacies now that are getting more creative. I remember just recently I was getting I think it was a foot cream or something. And I went to the pharmacy, and the price that they were going to charge me, I don't even remember. I want to say it was like $100 or something. And when I gave them my insurance, or when they had my insurance, then it was like, I think it was $60. And then I was like, well, hold on for a second. I said, I want to pay with GoodRx. And they were like, well, and then they make you wait longer. It's almost like they purposely make you wait because they're mad now because they're not going to get that much of a discount. But they said, well, hey, we can do it here. And again, I won't name the name of the pharmacy, but they said, we'll do it for XYZ price. So instead of the $15 and whatever cents GoodRx was charging. They ended up charging me, I think it was like 3 cents less because they wanted to make sure that they got it through cash paid through the pharmacy. So now the pharmacies are even getting smarter with it, which is, again, creating more of a benefit for the consumer, right? Because I actually saved, it's 3 cents, but what a penny saved is a penny earned, right? So, yeah. I mean, it's just amazing. Well, let's do this, David, and talk a little bit about what Free to Care is. I know we've got the Free to Care event that's coming up, Direct Primary Care Benefits Podcast. Thanks to you, will be in the house, and we're excited about being there and just sharing, our upcoming episodes with the listeners and the folks out there. But if you could talk about what the Free to Care event is, who will be there, and why people need to attend, and what you guys are looking to accomplish.
Well, great. Yeah, no, we've been around for almost 4 years now, and we are up to we are a member coalition. So we work with other advocacy groups from around the country, and right now we're comprised of 34 member organizations representing over 8 million people nationally, and including over 70,000 doctors. So about half of the membership of the American Medical Association.
Wow.
And so we advocate for, our mission is to amplify the voice of the doctor and the patient in the doctor-patient relationship. That's it. Because they're sick and they're tired and fed up of all of the runaround that they get, because they understand, like in the direct primary care relationship, that you just need to talk to somebody who knows what they're talking about.
Now, would you say that all of these physicians are anti-insurance, or are they just simply lack of transparency in insurance? How would you classify those?
They're across the board. Many of them are employed, and a lot of them work for hospitals. They work for different kinds of organizations. They're not all direct primary care. They're not all direct care. Many of them have moved in that way, but it's very difficult if you're a certain specialty to be able to move there. But that doesn't mean that they don't believe in it. And so they're very supportive from their role and are part of the process. But
Gotcha.
we just recently launched a new trade association here in Texas called Direct Care Texas. And if you are a direct care physician, whether you're primary care, specialty, or a cash price imaging center, surgery center, hospital, there's an opportunity for you to load your information there on the website, and we have a map where you can find someone close to you.
Nice.
So we're putting that in place, and we have a 2-day conference coming up next week on the 15th and 16th of September. It's our annual conference. And on the first day, we're going to focus on the federal issues that we've touched on a number of them here in this call. We're going to have, and it's important for people to understand that we try to be as nonpartisan as possible, because one thing that you'll hear all of us say is healthcare is personal, not partisan.
I love that.
It doesn't matter, what color tie you wear.
Or if you even wear a tie, right?
Or wear a tie, because when you're in the hospital, we're all wearing those ugly paper gowns. So that's really where our heart and our minds are coming from. So in that spirit, we have people on the right with Dale Folwell, who's a North Carolina treasurer. We have people on the left, and actually a Biden appointee for the first physician drug czar, Dr. Rahul Gupta. We have Junior Bryant, former Super Bowl champion with the San Francisco 49ers, who's going to talk about the problems he had with navigating the healthcare system after his traumatic brain injury that ended his career prematurely, and a number of others. The second day is going to be dedicated to direct care and that Direct Care Texas launch, because we want to have the lawmakers in this state, other states, and folks at the federal level recognize that this is a growing movement. It is surging. It really escalated during COVID, believe it or not, when many clinics were shutting down.
Do you think
we want to demonstrate that this isn't just direct primary care? We have cardiologists, rheumatologists, surgeons of all stripes, people that you wouldn't think are third-party free outside of insurance, but they're able to provide solutions to patients and employers at rates that are oftentimes 10, 15, 20% of what you would pay in the traditional system.
Unbelievable. Yeah, it's exciting. I mean, this is one of the most exciting times, I think, in healthcare, dating back from when I've just done my research. And you're right. You've got, surgeons. There was a sports medicine surgeon. I can't recall exactly what he did specifically, but I met him at a healthcare expo, and he was super excited about the podcast and what we were doing, because he himself is now moving in that space and looking to network with other physicians to essentially get what a real referral should look like, right? Not an insurance referral, but a referral that's like, hey, I've got a patient that needs this surgery, and we don't want to go and, rent out an expensive hospital room and do all of this. We can do this surgery, in a facility and, be outpatient same day. And, they're excited to embark on this new journey. And so I'm just super stoked, super excited about where healthcare is going and, the timing of it all. So I'm definitely super grateful and blessed to be in healthcare at this time and being a part of the change, right? I think that's what motivates you. And I'm sure that's what got you motivated. Back to what you were saying in the beginning was you saw where the holes were, right? You saw where the people weren't getting served. And you said, you know what, let me step up to the plate and be a part of the reform. So David, why don't you share with everybody that's out there how they can be a part of what you're doing and help further this movement, and how they can contact you or how they can just support you and what you're doing and what the Texas Policy Foundation is doing. Can you go ahead and share?
Absolutely. Well, for those that would like to attend the conference, the Free to Care conference next week, you can go to free2care.org is our website. You can find the event on Eventbrite. But you can find just about everything I've ever written at texaspolicy.com. And if you go to issues, and you can filter by my name, David Balat. But you can also find me. I'm most active probably on Twitter, LinkedIn, and Facebook. And we have a private group on Facebook called Right on Healthcare. And Twitter is David Balat HC, and just David Balat on LinkedIn. And feel free to engage or connect. And I'm usually good about responding relatively quickly.
Awesome. Well, I would definitely put all that information in the show notes, David. And listen, I appreciate you for taking the time to educate employers, brokers, all the folks that are out there that want to get more educated with healthcare. I appreciate you taking the time to do this today and being the inaugural guest on the Direct Primary Care Benefits podcast. So thank you so much for your time. And I'm looking forward to spending some more time with you here in the near future. And I'm looking forward to the Free to Care event next week.
Look forward to seeing you.
All right, David, have a great day.
Bye.
All right, God bless. Bye-bye. All right, guys. Well, that is going to be it for episode 1 here with Direct Primary Care Benefits. Please go and subscribe and like our channel, download all the episodes, and make sure that you are tuning in, because we are on a mission, and that mission is to fix healthcare. So with that being said, Brett Shoemaker here, your host, signing off. Have a great day. God bless, and we'll hear you next week.